Thank you all for joining us today, no matter when or how you're tuning in. I'm Dr. John Iskander. It's my pleasure to welcome you to CDC Public Health Grand Rounds for June 2017, Hearing Health Across the Lifespan. Public Health Grand Rounds has continuing education available for physicians, nurses, pharmacists, veterinarians, health educators, and others. Please see the Public Health Grand Rounds website for more details. We're grateful to our audience who recently helped us pass the 10,000 mark in CME credits awarded. Our disclosure for this session is noted here. Public Health Grand Rounds is streaming on Facebook Live. Please send comments or questions to the Grand Rounds email box, and find us now on Facebook Live and also on our website. Along with today's presentation, we provide interview segments on YouTube and our website called Beyond the Data. This month I interviewed Dr. Bill Murphy. We've also partnered with the CDC Public Health Library to highlight scientific articles about hearing loss prevention, and we also publish follow-up articles from past sessions in CDC's MMWR journal. Here's a preview of upcoming Grand Round sessions. Please join us live or on the web at your convenience. And in addition to our outstanding speakers, I'd like to acknowledge the important contributions of those individuals listed here and thank them for their work. And now we will have introductory remarks from CDC's Acting Director, Dr. Ann Schuckett.
Hearing loss is the third most common chronic health condition in the United States, surpassing diabetes and cancer. Most people think hearing loss is an inevitable part of aging, but it doesn't have to be. Studies show that hearing loss is associated with depression, loneliness, and stress. It's also linked to low employment rates, lost productivity, and high healthcare costs. Far too many of us have seen firsthand the impact that hearing loss has on a loved one. We've seen the stress, anxiety, and even stigma that can go along with hearing loss. My father served in the United States Navy during World War II and the Korean War. During his military service, he had extensive exposure to loud noise, which contributed to significant hearing problems later in life. For my dad, profound hearing loss was isolating and frustrating. And his story is far from unique. Nearly 1 in 3 U.S. adults, 61 million Americans, have high-frequency hearing loss. Every year, some 22 million American workers are exposed to hazardous noise levels on the job. But people with noisy jobs aren't the only ones at risk. Loud noises at home and in the community, such as mowing the lawn, attending concerts, or even being stuck in traffic with sirens blaring, are also hurting our hearing. And the damage often occurs before people notice or diagnose it, meaning this issue is under-recognized and under-reported. Today, you'll hear about what CDC is doing to identify, track, and prevent hearing loss, and to set standards to protect hearing. Experts will outline the importance of early identification and the current scope of hearing loss in youth and adults. They will also share insight on prevention strategies for individuals and organizations. Our concluding speaker from the World Health Organization will discuss the need for a global public health approach to hearing health. Although we've made progress, there's much work to do. Thank you for participating in this Public Health Grand Rounds.
Our first speaker is John Eichwald.
Thank you, Dr. Iskander. I'll be speaking about how federal agencies, and in particular CDC, is taking steps to communicate the need for preventing hearing loss in the community. In June 2016, the National Academies of Sciences, Engineering, and Medicine published Hearing Healthcare for Adults, Priorities for Improving Access and Affordability. Although this report co-sponsored by CDC and numerous other federal partners, focused on hearing health care for adults. It provides steps to support and manage hearing health and foster environments that maximize hearing and communication for all ages. The report's recommendations were developed by an exceptional 17-member committee with broad expertise in hearing healthcare services. 3 recommendations directed towards the CDC and other related public health partners included collecting, analyzing, and disseminating data on hearing loss in adults, promoting hearing health in regular medical and wellness visits, improving public information on hearing health, and promoting public awareness about hearing health care. Collecting, analyzing, and disseminating data is part of CDC's definition of public health surveillance. So, how do we measure hearing loss? This graphic represents an audiogram with varying degrees of hearing sensitivity. Across the top, frequencies or pitch are represented from left to right, and sound intensity or loudness measured in decibels of hearing loss ranges from very faint sounds at the top to very loud sounds at the bottom. Hearing is generally considered to be normal in adults when thresholds for all frequencies are better than 20 to 25 decibels. In children, normal hearing is generally considered when all thresholds are better than 15 decibels. What's it like to have a hearing loss? Listen to this recording. First, what the passage may sound like to a person with normal hearing.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
Now let's hear what it might sound like with a person with a mild hearing loss.
The rainbow is a division of white light into many beautiful colors.
Now what it might sound like with a person with moderate hearing loss. Sorry.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
And last, what it might sound like to a person with a moderate hearing loss in a noisy listening environment.
The rainbow is a division of white light into many beautiful colors.
CDC started research and participated in activities to raise awareness that exposure to loud sounds outside of a working environment can cause permanent hearing damage. We analyzed data from the 2011-2012 National Health and Nutrition Examination Survey. The 2011-2012 NHANES cycle included audiometric testing and hearing-related questions for a nationally representative sample of adults between 20 and 69 years of age. This morbidity and mortality weekly report was published as part of a larger health promotion launched as the February CDC Vital Signs Report, which included a media release, graphic fact sheet, website content, a town hall webinar, and multiple social media tools, most of which were provided both in English and Spanish. For our report, we analyzed audiometric data using an algorithm to identify high-frequency audiometric notches that were suggestive of hearing damage caused by exposure to noise. This algorithm was deliberately chosen to identify potential early damage to hearing even before participants might be aware that damage had occurred. This algorithm is the same as is used for reporting purposes in Healthy People 2020 to signify probable noise-induced hearing loss. But for our analysis, we included damage that was found in one or both ears. The graphic on this slide shows an audiometric notch in a person with normal hearing. A total of 3,583 adult participants had complete audiometric data for our analysis. The weighted prevalence of an audiometric notch was 24.4%, which extrapolated to the total population represents nearly 40 million adults in the U.S. Audiometric notches were identified nearly 3 times more often in one ear than apparent hearing damage in both ears. Audiometric notches in one or both ears were consistently found more often in men than in women. Participants who reported exposure to loud noise at work were twice as more likely to have hearing damage than those not exposed. However, nearly 1 in 5 participants who reported no exposure to loud or very loud noise at work had an audiometric notch in one or both ears. This means 21 million adults in the U.S. likely have hearing damage from loud sound sources at home or in their communities. These included participants who reported exposure to loud noise outside of a job, for example, noise from power tools, recreational activities, or listening to music for 10 or more hours a week. The presence of an audiometric notch increased with age, ranging from 19.2 among participants in their 20s to 29% in their 40s. The decrease in the prevalence of notches beginning for those in their 50s is believed to be due to the increasing effect of aging later in life that may mask the audiometric measure of damage already caused by noise exposure. You can graphically see that the notches identified in participants' left ears have almost completely been masked for those in their 60s, but this group still met our study definition and included in our analysis. Regardless of their work or recreational noise exposure, nearly 1 in 4 participants identified with this damage reported that they felt their hearing was excellent or good. This suggests many people with this audiometric configuration are either unaware or ignoring existing damage to their hearing from noise exposure. Almost all hearing loss from noise exposure is preventable. However, the NHANES survey found that 70% of persons exposed to loud noise in the past 12 months had never or seldom worn hearing protection. Noise reduction and avoidance can prevent hearing loss or slow its progression. Steps individuals can take for personal protection are relatively easy. Move away from the sound source of loud sounds, such as loudspeakers or cannons at college stadiums. Use quieter products and tools. Take break from exposures. Avoid high volumes on personal listening devices. Reduce listening time to loud levels of music, and use hearing protection. Hearing protectors need to fit well to reduce noise exposure effectively. You'll hear more details and specific case studies about these preventive interventions from subsequent speakers. Discussions between patients and personal health care providers about hearing loss symptoms, tests, and ways to protect hearing might help the early diagnosis of hearing loss and provide opportunities to prevent harmful noise exposures. Thank you for your time today. Our next speaker is Dr. Deanna Meinke.
Thank you, John. As mentioned, repeated noise exposure to high levels of sound causes noise-induced hearing loss. The hearing loss is due to auditory damage of the inner ear structures of the cochlea. Repeated exposures to loud noise can damage fragile inner ear hair cells to the point that they won't recover. Healthy hair cell bundles, or stereocilia, are pictured on the left, while noise-damaged hair cell bundles are depicted on the right. Repeated exposures to high levels of sounds eventually cause the hair cell to die, and secondary cochlear nerve loss occurs. It takes the loss of multiple hair cells before hearing loss becomes apparent on the audiogram. In humans, these hair cells do not regenerate, and they're permanently lost. Noise exposures may cause a temporary change in hearing, such as that experienced a day or so after attending a loud concert, and were previously considered benign without long-term consequences. Recent animal studies now indicate that these noise exposures can cause permanent loss of greater than 50% of the cochlear nerve hair cell synapses that do not recover on their own across multiple species. Kujau and Lieberman's lab has also shown the risk of early noise exposures contributing to greater age-related hearing loss in the future due to the loss of the cochlear neurons in the spiral ganglion. Since this loss of cochlear neurons does not impact low-level auditory detection at threshold, the audiogram remains normal and is termed hidden hearing loss. It may be true that one concert truly does age your ears. It is important to understand that the risk of hearing loss is a combined effect of the sound level and the duration of listening. Continuous sound levels are quantified using A weighting, which shapes the noise measurement to match the sensitivity of the human ear. Just like sun exposure and skin cancer, the longer you are in the noise hazard without protection, the greater the risk of noise-induced hearing loss. The absolute safe sound exposure limits for children and adolescents are unknown, and therefore we typically reference the adult exposure tables. Permissible noise exposure tables, such as this one from the noise exposure limits published by the National Institute for Occupational Safety and Health, are based upon adult occupational noise exposures developed with some degree of acceptable risk of hearing loss, assuming repeated exposures over 40 years. It's important to understand that these are daily exposure limits, and hearing loss would only occur after repeated exposures over many years, not after a single exposure to continuous noise. The U.S. Environmental Protection Agency and the World Health Organization published a more conservative noise exposure limits based on a 24-hour day as opposed to an 8-hour workday. These limits were developed to eliminate any risk of high-frequency hearing loss in adults. Acoustic trauma is the risk of immediate mechanical damage from impulse or impact noise to the unprotected auditory system. Sound pressure limits are set at 140 dB sound pressure level for adults by NIOSH and 120 dB sound pressure level for children by the World Health Organization. When measured at the ear, youth firearms range from 140 to 171 decibels peak sound pressure level, and firecrackers at a distance of 1 meter average 162 dB peak sound pressure level, and can cause instantaneous hearing loss if the blast is close to the ear. As mentioned previously, continuous noise exposure leads to the gradual onset and progression of noise-induced hearing loss. The hearing loss produces a characteristic notched pattern on the hearing test results, or the audiogram. Niskar et al. Used a notch criteria quantified by calculating the metrics specified on this slide. An example from a high school student is provided in the audiogram here, where the blue squares are the left ear and the red circles are the right ear. And it resulted from continuous exposure to noise in both ears. Whereas the second audiogram resulted in a unilateral notch from a firecracker blast closest to the right ear of this student. Noise-induced hearing loss in youth is not necessarily a new problem, but it is a present and potentially growing problem. Locke in 1943 was the first to report 15% of males and 5% of males having a 4,000 hertz audiometric notch on data collected from high school students in Baltimore, Maryland. This compares to Niskar et al.'s study in 2001, which reported notched audiograms suggestive of noise-induced hearing loss in 20% of males and 12% of females. Henderson et al. Repeated the Niskar study in 2011 and used NHANES data from 2005 to 2006 and found the percentage of youth with notched audiograms actually decreased in males to 17%, but increased in females from 12 to 17%. The evidence for noise-induced hearing loss in youth appears to be more equally distributed across the sexes now. Of note is our study from 2007 that reported that only 22% of the 22 different hearing screening protocols used in United States schools will be able to detect early noise-induced hearing loss in youth. Consequently, school hearing screening should not be relied upon for the detection of noise-induced hearing loss in youth. It's also worth noting that middle school and high school students are less likely to have a school-based hearing screening at all. At-risk youth should be referred to an audiologist for hearing testing. Hazardous noise exposure not only leads to noise-induced hearing loss, but also tinnitus or tinnitus, which is ringing or buzzing in the ears. This is a simulation of tinnitus. Imagine having this never-ending sound disrupt your days and your nights. Bobby et al. Determined the prevalence of tinnitus in youth aged 12 to 19 years from data collected during the 2005 to 2008 NHANES data. Approximately 7% or 2.5 million adolescents reported having tinnitus for 5 minutes or more during the preceding 12 months, and approximately 5%, or 1.6 million, reported chronic tinnitus lasting more than 3 months. So that accumulates to 1.6 million youth with that problem. Recreational and occupational noise exposure increase the odds of tinnitus in these youth. It's important to pay attention to tinnitus as an early indicator of noise-induced hearing loss. The media and the World Health Organization has focused great attention on personal audio systems or music players over the past decade. The average maximum output levels are 97 to 103 dBA. Risk estimates for youth based on their self-reported listening time and the measured listening levels range from 14% to 30% of youth being at risk of noise-induced or music-induced hearing loss. Studies report that males listen approximately 5 dB louder than females. Just as with other noise exposures, the risk of noise-induced hearing loss is a result of the cumulative exposure across all high-level sound exposures. Therefore, for youth participating in other noise hazardous activities, it would be important to consider these other exposures when determining allowable listening times. For most music players, listening with a volume control setting below 60% of the range would likely allow a listener to enjoy their music for an unlimited amount of time. All of the landmark studies over the past 75 years that identified the risk of noise-induced hearing loss in children and adolescents ended with a recommendation for education and intervention to address the problem. In 1990, the Institutes for Health called for a comprehensive program of education regarding the causes and prevention of noise-induced hearing loss should be developed and disseminated, with specific attention directed towards educating school-aged children. Education continues to be a focus today as part of the Healthy People 2020, which calls for an increase in the proportion of elementary, middle, and senior high schools that provide school health education in ways to prevent vision and hearing loss to promote personal health and wellness. There continues to be a need to nationally coordinate public health efforts to systematically address the prevention of noise-induced hearing loss in children using evidence-based hearing health promotion based on health communication science. Health communication science provides a theoretical framework to study, develop, and evaluate interventions designed to change an individual's behavior to prevent noise-induced hearing loss and tinnitus. Health behaviors can be categorized into 3 levels. 1, interpersonal level theories predict how knowledge, attitudes, beliefs, and other traits within the individual will affect health behaviors. 2, interpersonal level theories describe and predict a person's relationships with others, and their social identity and normative expectations will affect their health behaviors. And 3, community level theories predict how organizations, regulations, and policies can affect health behavior. Some of these theories have been applied in hearing health promotion, and one such theoretically based program is Dangerous Decibels. Dangerous Decibels is a successful evidence-based intervention program that has been demonstrated to be effective in changing knowledge, attitudes, beliefs, and behaviors of both youth and adults for the prevention of noise-induced hearing loss and tinnitus. The program has been shown to be effective in randomized trials in children in the U.S. and in studies conducted in New Zealand and Brazil. Although originally developed for youth, it has been successfully adapted for adults and the military. Most recently, it's been expanded into community-based intervention and shown to be self-sustaining in U.S. Native American communities. The messaging incorporates 3 strategies for hearing loss prevention: turn it down, walk away, protect your ears. Currently, the program is being disseminated in the U.S. as a grassroots effort by individuals attending a 2-day training workshop and returning to their local communities to voluntarily teach the program. Materials are currently used in all 50 states, 4 U.S. territories, and 41 countries. Web-based games and activities are available online, as well as instructions for creating your own Jolene, an educational mannequin designed to measure music listening levels and used in educational outreach regarding hearing health. Please feel free to contact me regarding more information on the program and its resources. We have also posted a link on the CDC Grand Rounds website. Additionally, Dangerous Decibels is pleased to offer CEUs for audiologists completing this Grand Rounds. Please email Dangerous Decibels at dd@unco.edu for details, or check the Public Health Grand Rounds website. Thank you for your interest, and our next speaker is Dr. William Murphy.
Well, as we have already heard, millions of persons in the United States are affected by hearing loss. For many persons, that hearing loss can be attributed to their occupation. For others, the hearing loss may be attributable to their recreational or other exposures that they've experienced. In addition to noise, several causative factors for hearing loss exist. Impulsive noise at high sound pressure levels can be more hazardous than continuous noise at the same level. High noise levels can cause hearing damage before it is perceived as being too loud. Ototoxic chemicals can interact with a noise exposure and perhaps produce more hearing loss than the noise or the ototoxicants in isolation. And genetics affect the individual's susceptibility to both noise-induced hearing loss and age-related hearing loss. Whether it's listening to that personal stereo, attending a rock concert, or working in a factory, noise exposures above 85 decibel sound pressure level can cause hearing loss. Recreational activities such as target shooting or setting off fireworks can expose your ears to levels between 120 and 175 decibels. At these levels, hearing loss can occur immediately. At work, at home, power tools, lawn care equipment, exposures to sounds of high levels can fatigue the sensory hair cells of the cochlea and lead to hearing loss over repeated exposures. Now, the good news is that these noise exposures are preventable. Reducing or eliminating the high-level noise exposures by using quieter power tools or wearing properly fit hearing protection are excellent strategies to prevent hearing loss. While noise exposures can destroy the sensory hair cells of the cochlea, ototoxic substances can damage hearing through a variety of mechanisms. Aminoglycoside antibiotics and some chemotherapy medications can wipe out hair cells that convert mechanical motion into electrical nerve impulses. Organic solvents such as toluene or styrene can poison the supporting cells of the basilar membrane, and certain metal exposures can cause demyelination of the nerves of the auditory pathway. Asphyxiants can affect the oxygenation of the blood that's supplied to the cochlea and lead to increased stress on the sensory hair cells. Pesticides are designed to be toxic and can affect hearing through a variety of mechanisms. Starting in 2009, the National Institute for Occupational Safety and Health Occupational Hearing Loss Surveillance Program partnered with hearing conservation providers throughout the United States to collect millions of audiograms for analysis. Now, depending upon the particular industrial sector, the estimated prevalence of hearing loss can be between 12 and 25%. Some sectors have exhibited a decreased prevalence over time, notably the agriculture, forestry, fishing, and hunting sector, and the transportation, warehousing, and utilities sectors. An analysis of the National Health and Nutrition Examination Survey data found that workers in the mining sector had the highest percentage of self-reported exposure to high noise levels, followed by lumber and wood manufacturing and other industries listed on this slide. From 2004 to 2015, the Bureau of Labor Statistics has reported a reduction from 28,000 to 18,000 workers who have suffered occupational hearing loss. NIOSH estimates that approximately 22 million workers are exposed to hazardous noise levels. The risk of incident hearing loss has been reduced by nearly half relative to the period from 1986 to 1990, and the relative ratios range from 44 to 60%. Now, these statistics are important because they suggest that hearing loss prevention efforts within occupational realm are having an effect. A recent analysis of the NHANES data from 2011 to 2012 suggests that the public at large is also experiencing a decreased prevalence of hearing loss. About 31% of U.S. adults aged 20 to 69 have hearing loss. That's 61 million persons. And that's a slight reduction from earlier estimates. Now, after we adjust this for age and sex, men had nearly twice the prevalence for high-frequency hearing impairment. And by that, we mean more than a 25 dB average at 3, 4, and 6,000 hertz. Age, gender, ethnicity, occupational noise exposure, and education were all significant risk factors for hearing loss. Our efforts are having an effect, but the problem is still large. So what do we do? Well, here's an approach. If we can eliminate a hazardous exposure, that's going to be the most effective approach. If we can't eliminate it, then perhaps we can find a way to substitute for that process and do the same job, but without as much hazard. Compressed air, inadequate enclosures, loose bearings or belts, metal-on-metal collisions are potential occupational noise sources that have simple noise control engineering solutions. Administrative controls are used to limit the amount of time that a person is exposed or the amount of exposure that someone might achieve. Finally, and perhaps least effective, is the use of personal protective equipment, that is, hearing protection devices. Now, we point to those as being the least effective because hearing protection is the most easily defeated. All you have to do is take it off. Hearing protection can work, but it has to be worn correctly and consistently. NIOSH has developed a number of innovative solutions to the occupational hearing loss problem, and I'm going to describe these in the next couple of slides. New technologies can improve the way that we test hearing. The headphones shown have integrated digital audio processors and increased noise isolation. Dr. Mikey recently field tested these headphones for conducting hearing screenings at an industrial facility. If a physician or an audiologist wanted to test speech intelligibility, hey, there's an app for that. A device such as this could remove the barriers for hearing screening by physicians and occupational health professionals, both in occupational and non-occupational settings. Another solution is fit testing of noise reduction of hearing protection devices. In a NIOSH field study, we found that less than half of the workers were able to achieve adequate protection for their earplugs. We are working with hearing protector manufacturers and hearing conservation professionals to develop accurate descriptors of hearing protection performance as measured by fit test systems. NIOSH has championed the philosophy of buy quiet to promote the substitution of quiet tools for noisy tools. Listen to this recording of two different circular saws. First, you'll hear the quiet one, and then the loud one. Buy quiet programs encourage employers to catalog tools that they have and then to make intentional decisions to replace current inventory with quieter tools without sacrificing the performance of that tool. The NIOSH Power Tools database provides consumers with sound power ratings for a wide range of tools. Now, you're saying, how does this apply to me? Well, outside of the occupational setting, I want to see a show of hands of how many people have purchased a quiet dishwasher. All right, maybe 10 to 15%. Dishwashers have sound power ratings on them that are used to describe the noise that they emit, and the industry has been successful in creating a demand for quiet appliances. One immediate benefit of implementing buy quiet programs is the reduced risk of hearing loss. Another benefit is a cost savings through reducing the burden of administering a hearing loss prevention program. A quieter workplace translates to a lower risk of running afoul of workplace regulatory requirements. Quieter workplaces actually can result in improved communication, improved worker safety, and can reduce the impact of noise on the community. NIOSH and the National Hearing Conservation Association developed the Safe and Sound Excellence in Hearing Loss Prevention Award. Individuals who have developed innovative solutions for hearing loss prevention or companies that have implemented excellent hearing loss prevention programs are eligible for the Safe and Sound Award. The success stories are used to promote these solutions and to raise awareness among the public. Since 2009, 20 organizations have received the Safe and Sound Award. Individuals in industrial sectors for manufacturing, services, and construction have been recognized. Corporations, state and local government entities have received the award. And in fact, the Dangerous Decibels program that Dr. Meinke helped to create received this award in 2013. Pratt & Whitney received the Safe and Sound Award in 2009, and their parent company, United Technologies, was similarly honored in 2015. United Technologies applied the solutions and principles across their entire corporation to reduce workers' noise exposures. Practical noise control solutions and a Buy Quiet program reduced the number of employees exposed to excessive noise from slightly more than 10,000 workers to about 2,000 workers. The message that can be learned from this is that noise control is achievable and it's desirable. Each of us who own a smartphone or a tablet have the ability to make noise measurements. From the most expensive commercially available sound level meter to the free NIOSH sound level meter app, the microphone must be calibrated in order to get accurate readings. The phone shown here running the NIOSH sound level meter app has an external microphone which was calibrated. When we are knowledgeable about our exposures, then we can avoid them. That's administrative control. When we wear hearing protection devices in noisy environments, that's personal protective equipment, and we can prevent excessive noise exposure, and that's PPE. Many items have been covered in this short presentation, and as adults, we have the tools that can measure the noise exposures that we experience. From our research on powered hand tools, if you're using a tool for construction, you probably should be wearing hearing protection. If you can find ways to reduce the noise exposure or to control the exposures, take advantage of solutions that have already been identified. Lastly, if the noise is in excess of 85 decibels sound pressure level, then you probably should find hearing protection that is comfortable and which you will properly fit in your ears. Remember, hearing loss prevention has to be applied both in the workplace and at home. Thank you for your attention. Our final speaker is Dr. Shelley Chadha from the World Health Organization, and she joins us from Geneva.
Good afternoon, everyone, and greetings from the World Health Organization. Following the earlier speakers who have spoken on some of the causes of hearing loss and their prevention, I would now like to give you some global context on this issue and also share with you the thinking and approach of WHO towards addressing this problem. Over the last few decades, we have observed a steady increase in our estimation of the number of people that live with hearing loss across the world. Latest estimates suggest that world over, there are 360 million people with disabling hearing loss, which includes moderate or greater degrees of hearing loss, but it excludes unilateral hearing losses. It is also possible that the coming years will see a much greater increase in these numbers. And this projected rise is likely due to three main reasons. Firstly, there is an evident shift in global population demographics with increasing number of older adults. Considering that 1/3 of them will have hearing loss, it is expected that there will be over 320 million older adults with hearing loss by the year 2030, and this number could well be over 500 million by the year 2050. The second factor contributing towards this projected rise is the increasing practice of listening to loud sounds for long periods of time. We estimate that globally, over 1 billion young people are at risk of developing hearing loss due to the way they listen to music. Besides these, there are many well-known causes of hearing losses which continue unchecked and contribute to the increasing prevalence of hearing loss. In addition to those which have already been mentioned by the previous speakers, chronic ear infections, which are still widely prevalent in lower and middle income countries, infectious diseases, birth complications, and chronic illnesses contribute to the global burden of hearing loss. Unless hearing loss is addressed suitably, it has a significant impact on the lives of those who are affected by it, as well as their families, the community, and the country as a whole. It is a barrier for communication and language development. Hearing loss is associated with delayed cognitive development in children and early cognitive decline in older adults. Moreover, unaddressed hearing loss restricts educational and employment opportunities. It hampers social interaction and emotional well-being, and it often poses an economic challenge. As a matter of fact, WHO estimates that each year unaddressed hearing loss costs us $750 billion globally. Hence, it is essential that this looming hearing loss epidemic be controlled. So the first question we face is, can we control this epidemic? And the answer to that ought to be yes, mainly because, many of the causes which lead to hearing loss are preventable. And when hearing loss does occur, timely and suitable interventions can mitigate its impact and ensure that people with hearing loss have a chance to reach their full potential. So the next question then is obviously, how? How can we control it? The answer to this question, of course, is not so straightforward. What we need to do first is to address hearing loss as a public health issue and apply a life course perspective to it. Applying a life course perspective to hearing loss allows us to understand that there are many factors over the course of an individual's life which impact their hearing health. Our hearing is the outcome of our genetic makeup, of environmental exposures we face, for example, exposure to noise or ototoxic medicines, of comorbidities that we suffer, such as diabetes or hypertension, and lifestyle choices made, for example, smoking or getting regular exercise. Taking this holistic view towards hearing allows us to understand that there are opportunities for prevention and risk reduction at many points across the life course. And of course, when hearing loss occurs, early identification and interventions can greatly assist or help in mitigating its effect. Once we acknowledge this potential to reduce and mitigate hearing loss, we need to adopt a public health approach towards it. So, what is this public health approach? A public health approach is essentially a population-based approach which goes beyond clinical service provision with its traditional areas of diagnosis, treatment, and research. A public health approach attempts to identify the needs of the population as well as the barriers which are posed to care, with the aim to develop and implement policies in order to prevent and manage hearing loss. A public health approach does not just focus on identification and management of clinical cases, but it focuses also on epidemiological surveillance, on health promotion and disease prevention. Following this public health model, WHO, in its work on deafness and hearing loss, focuses on undertaking evidence-based advocacy with the aim to raise awareness on hearing loss and hearing care at all levels, and on driving and supporting policy development in its for hearing care provision in its member states, that is the 195 countries that are members of the UN system. In order to support policy development, WHO develops standardized technical tools, recommendations, guidelines, training resources, etc., which our partners and countries can use and refer to for technical guidance. WHO also engages directly with ministries of health and other stakeholders in countries in order to develop, implement, and monitor strategies for ear and hearing care. For the purpose of advocacy, WHO drives two key advocacy initiatives in this area, the World Hearing Day and the Make Listening Safe initiative. The Make Listening Safe initiative was launched by WHO in 2015 with the aim to reduce the growing risk of hearing loss which is posed by unsafe listening practices in recreational settings. As part of this initiative, WHO is working to develop a communication campaign, and this is aligned to some of the communication principles which were already mentioned by Dr. Mienke before me. WHO is also working with partners to develop technical standards and software applications for personal audio systems which promote safe listening practices amongst their users. Besides this initiative, the main advocacy event for this program is the World Hearing Day, which is observed each year on 3rd March with the aim to raise awareness about hearing loss at all levels, that is, amongst policymakers, professionals, and within communities. Each year, WHO identifies a theme and it develops evidence-based advocacy messages and materials. These are made freely available by WHO, and over the past many years, number of organizations, countries, and professionals have joined this effort by observing this day and undertaking activities to raise awareness and provide services. I invite all of you as stakeholders in this field to also join hands with WHO and become a part of this global effort. The fact is that neither WHO nor any other organization can face this challenge alone. Each one of us has to become a part of a greater global effort and play our role, whether we are service providers, researchers, members of professional bodies or NGOs, whether we represent industry or user groups, or belong to governmental or UN agencies. We must work together to further this common cause and to realize our vision, which is the vision of a world in which no person experiences hearing loss due to preventable causes, and those who do have hearing loss due to unavoidable causes can achieve their full potential through rehabilitation, education, and empowerment. Thank you very much for this opportunity, and I hand back to Dr. Iskander for further comments.
Thank you very much, Dr. Chadha. We've been attempting to link her in as well for the Q&A session, and we'll continue to do so. To moderate the question and answer, I'll turn the podium over to Dr. Murphy, or he can moderate from where he is right now. That'll work too.
That's fine. Thank you. Questions? Questions from online?
We do have questions from online. I'd like to remind all of our viewers to send questions to grandrounds@cdc.gov.
So send questions online to grandrounds@cdc.gov.
And we're pulling up our questions now.
We have one in the audience here. Yes, sir.
Hi, Abhijit Anand from Global Immunization Division. I had a question about commercial air travel and hearing loss. What's the evidence around that? Especially, as you would know, there are the amount of exposure of commercial air travelers can vary quite a bit, and some of frequent travelers can accumulate a fair amount of travel.
That's an interesting question. We've had a little bit of work at NIOSH, more focused on the flight attendants and the risk that they may face. And one of the things that they had to do is they're not necessarily allowed to wear hearing protection because that might give the impression that it's hazardous. It is noisy. There's no doubt about that. You, as a consumer of air travel, there are very simple things that can be done. You can put on hearing protection. You could wear the noise-canceling headsets that many persons have. But then again, you also have to worry about whether you, as the consumer of that air travel and the customer, are listening to your music at a high level, which might negate any benefit that you have of canceling out the noise from the air travel. I have a close friend who is a stewardess, or I guess a steward. He calls himself a stewardess in the sky. But he talks about putting in his earplugs as they ascend and as they land, which are the two noisiest times on the plane. Other questions?
Hi, my name is Megan, and I was curious, there's some studies being done, I believe at the University of Iowa, on the connection between musicians and improved hearing later in life, like band musicians and choral singers. Have you heard about any connections between that? They've also started doing some studies to see if they can train senior citizens to sing in a choir or play in a band to see if they can improve hearing loss. It sounds like it's in the early stages, but.
Yeah, I guess we're kind of looking at each other. I'm not directly familiar with that research. There's always been some question about music itself as an exposure because it has a different spectral quality. It has different temporal components to it. So it's not the same as your circular saw running continuously. So there's lots of evidence that having rest and some strategies that musicians use may protect them somewhat. But I think, as far as I know, the jury's still out on that. But I know there's lots of interest in it. And I also think that there's lots of interest in music and the brain and being able to sort out what you want to hear from what you don't. And it may be that they're looking at just the listening abilities. Even though you have hearing loss in your ear, your brain may be able to compensate or adapt with it better. So I guess that would be my best answer for that.
Go to a question online.
Yes. From Jean in Iowa. Please ask them to address how to get teenagers to stop the earbuds obsession. My 19-year-old daughter has them in all the time, cannot hear me talking to her, and I'm getting blue in the face trying to get her to stop. Throwing the earbuds in the trash doesn't work. They can just go to CVS and buy another pair for $17 or less.
I guess I'll take that one. So, I mean, earbuds, music listening is here to stay. It's a passion. It's what people like. And the message isn't not to listen to your music. It's to listen responsibly and to want to listen for a lifetime. So that's one of those behavior changes we have to get to. And one of the best ways that Dangerous Decibels has some evidence for is that you teach the adolescents who are risk takers. They're invincible. They don't recognize things that are going to happen years down the road. And you teach them to teach the younger kids. They don't want to be hypocrites. So the best outcomes we've found in high school students and adolescents is to get them engaged in teaching younger kids.
Other question?
Yes, sir. My name is Larry, and a couple of years ago, my wife and daughter thought I maybe had a hearing loss and basically forced me to go see an audiologist, which I did. I went just right down the hill here at Emory University Hospital. And it did turn out I did have a hearing loss, which I didn't know I had, and it was somewhat significant, but they looked at it, and what they also found out was I had a lifetime buildup of earwax. So they went in and they cleaned out my earwax, which took maybe 20 minutes, and it was fine after that. So I just wonder if there's any literature recommendations or anything like that about just checking earwax buildup as a possible cause, particularly for older Americans.
I'm not aware of any actual recommendations, although obviously it should be on. Yeah. Not aware of any, like U.S. Preventive Service Task Force, I don't believe has any recommendations on it currently, but I would think that would just be good common medical practice, and certainly to get hearing rechecked after you've ruled out any conductive component to make sure there's still not an underlying sensory neural hearing loss.
Thank you.
Another question from Bridget. How can public health educators take an active role to meet CDC recommendations to prevent hearing loss?
How do public health educators take an active role to prevent hearing loss? I think this is one example of trying to do that. I mean, this has been a long-time effort. For those that aren't aware of it, we proposed this a year and a half ago, I believe it was, and have been in the process of trying to plan and trying to get a message out. It's really rewarding to see this occur. In my 2 decades and plus of work in the government, we've not had, I think, a public health grand rounds or an effort like this to get this information out. Now, there are many other opportunities. The dangerous decibels is a great opportunity. We've had campaigns with the National Institute on Deafness and Other Communication Disorders, the Wise Ears, there's Noisy Planet. NIOSH has had our efforts in trying to communicate and get the message out. And agencies that I've worked with or organizations that I've worked with, such as the National Hearing Conservation Association, hearing conservation is their middle name. And those folks are passionate about what they do. And if you want to find out how to be involved and how to do that, I recommend contacting the people at NHCA. That's kind of my second home for organizations that I work with. And the other one is the Acoustical Society of America. Being a physicist and interested in acoustics, that's the other area that I do a lot of work with. But I think NHCA is a very strong advocate for hearing health education. So there's a question here in the front.
So I know the focus of the session is on hearing loss, but I was wondering if somebody could comment on the non-audiologic health effects of noise as well and how that might fit into some of the discussion we're having.
So issues on non-audiologic effects, well, certainly one of the areas it's been researched, but I won't say that we've been able to focus a lot on it at NIOSH, which is things related to their sleep disorders. You can have interruption of sleep due to noise in the community. This morning, I was awakened at about 6 a.m. by, I don't know, it was construction or the garbage truck or whatever it was outside my hotel, and I thought, boy, isn't that just suitable? Here I am for It's Loud Out There, hearing health across a lifespan, and I'm awakened by the garbage truck in the morning. There are issues with, arteriosclerosis and potential low-frequency noise exposures. We've had questions on that with airline personnel and people that have exposures that way. And I think there's a variety of other exposures that are slipping my mind at this point, but it's difficult to try to investigate some of those when we're being put in our goal and our focus at CDC now is really on burden, need, and impact. What's the most critical element and what's the most important element for us to research? And some of these other ones are very small with respect, but everybody's hearing is an important element. So, Deanna, sure.
So I guess the only other comment I'll add is that those non-auditory effects of noise are typically at levels lower than what we're talking about at 85 and above that damage hearing. So at 70 and 75, you may have those systemic effects. And in the U.S., we're not very good at having involvement in that community noise issue. The Environmental Protection Agency has been defunded since the 1980s, so no one's really home looking at that here. The European Union and some other parts of the world have some excellent models and information for being able to look at that, I think. But speaking from dangerous decibels, there is lots of concern about that. We just don't have a good source here in the U.S., I think, to deal with it as well. But buying quiet would certainly help with some of those things.
All right, we have time for 2 more questions, so we'll go to the mic.
So Stuart from NCBDDD, and so my question involves the effects of loud noise exposure on earlier in the life course than childhood and adolescence. So this is in relation to pregnant women and the effects of loud noise on the development of hair cells in the fetus. So what's known about this line, as well as the effects of ultrasounds on hair cell development?
Well, I'm not aware of any human research on that topic at all. Just ethically, it would be very difficult to do. When they did, Ken Gerhardt at Florida, I think years ago, was doing research in fetal sheep. And because the fetus is in a fluid environment, sound is transmitted very differently through that. It's actually a good sound isolator. And so unless the pregnant woman was coupled to a vibratory source, it doesn't look like you're getting the same sorts of effects on a pregnancy that you would out in the air, per se. In terms of ultrasound, I'm not aware of any studies that have showed a risk for that. The frequency of hearing and the age of development would probably impact that, but in terms of hair cell damage itself, don't know.
And we will take our final question from our online audience.
Yolanda would like to know, why doesn't Medicare pay for hearing aids?
No comment.
I'm CDC. I'm not that part of HHS.
Yeah.
I don't
think that's a question we really can address.
I'll offer that whenever I've talked to insurance companies, I've not talked to Medicare, but they tell me that no one asks for it. They tell me when you get asked what you want on your insurance to cover, people ask for eyeglasses, they ask for other things. Hearing loss is invisible, people don't advocate for it, and the people that have hearing loss are the least able to communicate in our systems. So we just need people out there asking for that benefit, I think.
All right. Thank you all very much. Let's hear another hand for our speakers. Thanks again for those of you who joined us in person. The CDC Library has assembled some materials along with the National Center for Environmental Health and one of our guests, and those are available on both the first and second floors of this building. Please join us next month and every month for Public Health Grand Rounds.